Hello and welcome to the iMedX Best of Day series. My name is Dr. Joseph McHale. I'm a hematologist at Mayo Clinic in Arizona, and it's my pleasure to be the chair of the series as we are here at our annual hematology meeting in San Francisco, speaking to experts about what is new and exciting at the meeting and what implications they will have for what we do in clinical practice. It's a particular joy today to invite our colleague and good friend, Michael Morrow, who is a hematologist who focuses in myeloproliferative neoplasms, and in particular we're going to be talking to him today about CML. Michael, welcome.
Thanks for having me.
Oh, it's great to have you here. So let's jump right into it, and we know that CML has been one of these diseases over the last decade that has had so much press and popularity despite not being that common. With imatinib and then dasatinib and nilotinib, you know, us myeloma doctors are trying to keep up with all the names of your drugs. Anything in the frontline setting that is worth noting that's presented at this meeting?
You know, for frontline treatment of chronic phase CML, we have actually pretty robust follow-up. We now have 5-6 years of follow-up from some important randomized trials that were originally published in the New England Journal, randomized trials of nilotinib versus imatinib.
Okay.
And then this year at this meeting we had information on final follow-up from the dasatinib versus imatinib trial. So we clearly want to look at the long-term follow-up of those studies for differences in survival, toxicity questions, really the final story on outcome.
So let's talk a bit about that. So looking at imatinib versus dasatinib, any significant differences in this long-term in survival?
So as the study was followed through the years, we saw early on cytogenetic response advantages, and now with 5 years of follow-up, we see molecular response advantage.
Right.
And it's held up. I mean, that was the important question. Would it continue to be sustained over the duration of the study? So MR3, which is a major molecular remission, 3-log reduction. MR 4.5, which is so-called complete molecular remission, also better with dasatinib. This and other studies like it have not shown differences in survival, though. There are improvements in progression events, stopping progression events. There's improvements in the molecular response, and we expect they would translate, but they haven't yet.
Really?
So and some of the reasons could be late toxicity, losing patients off trial because they're then counted as non-responders, and so there are some clear reasons. But overall, the drug's well tolerated. There weren't new toxicity concerns in the vascular realm, particularly with dasatinib, which was reassuring. No major difference between the imatinib and the dasatinib-treated patients, and that's really an area of focus, is that asking about that question. So that was encouraging.
So now the average clinician is left with like 3 options, really. Were there any unusual toxicity signals that were detected later on in this 5-year follow-up, or were they the ones that you kind of expect with these agents?
The one that's focused on mainly is that pleural effusions can continue.
They can?
Yeah, okay. So we see them even through the 4th and the 5th year study. I think we probably have some more work to do to sort out why those occur, how to manage them, what's the underlying mechanism of action. I think the good news is they may not be as morbid as some of the vascular occlusive events we're seeing with other drugs, but yet they're still high frequency and requiring management. So that was a little bit of the focus.
So for the practicing clinician trying to put this all together, when they decide on what agent they're going to start with in a newly diagnosed patient with CML, I guess really in a sense it's dealer's choice, right? I mean, they've got a choice between the 3, and do they choose based on what toxicities they may be concerned about more than true efficacy?
I think you certainly should consider the patient and their risk, their so-called risk score, which looks at what you'd expect, the blood counts, the age, the spleen size, the kind of the characterization of the CML, how robust or how proliferative is it. But it is, for the, in a sense, dealer's choice, because I think there's merit to imatinib. There's going to be a lower cost option with imatinib coming in the next year. The data is pretty convincing, though, for improvements in molecular remissions, and I think we just have to kind of look for what the translation of that will be. I think in a few years we might know a little bit better that molecular responses could really make patients more amenable to treatment discontinuation, or give us different survival information. So for now, it's a little bit of a subjective individualization, patient to patient, and the same thing goes for monitoring once you're on therapy. So
let's talk a bit about monitoring, because I know that's something that came up quite a bit, as I understand, is that it's one thing, obviously, and you've led the way. I'm going to be careful how I say it, give too much credit to the CML world, but in understanding molecular responses. So anything from a response standpoint that's been important at this meeting?
Well, we have guidelines, and we have pretty important information about what testing should be done. We actually presented on a study called the Simplicity Study, which is a registry of how patients are treated in the frontline setting, imatinib, nilotinib, dasatinib across Europe and the U.S. Unfortunately, we're not monitoring like we should.
Really?
For example,
so tell me more about that Simplicity Study. I mean, are we a little bit off? Are we way off? What's happening in the real world?
We have some work to do. Looking at how many patients, for example, would get the right number of milestone assessments within a year, 3 or 4 tests, probably half or less.
Really?
Yeah. So I mean, the testing is going to vary and it's going to be individualized, and it may be that patients aren't necessarily all missing milestones. When we looked at response, which is what we focused on from this study at this meeting, there was benefit to the second-generation kinase inhibitors. The responses were not far off what we'd expect, and imatinib showed that it unfortunately led to a few more cases than dasatinib and nilotinib meeting failure criteria based on guidelines. So it's consistent with what we'd expect, but we've identified the gaps that the monitoring is not as per guidelines. And I think as the years follow in this kind of study, with registration, a large number of patients, we can ask about cost and patient-reported outcomes, which will be important. Why do we change? Things like that.
Was there a particular, just out of interest, I mean, was there a particular test that people were missing in general? Was there at a certain time frame or a metric that was the culprit the most of what we weren't looking for or checking for?
I think we're in an era now where molecular testing is probably sought more because it's more patient-friendly. And honestly, a lot of our data, including in this meeting around what's the best timing regarding early molecular monitoring. Right. So it was being used. It might be not enough, but I don't think there was any one particular violation.
But in general, so one of the take-home messages for our clinicians today, they're listening to this, hearing you speak, saying, "Ooh, I should really stick to the recommended schedule of molecular monitoring because it makes a difference." What argument are we going to bring to them to make sure that it's important for them to know that if they don't, there can be issues?
Well, this is where it gets tricky because coming out of this meeting as well, I don't know if someone would take away that it's crystal clear with regards to what is the best early landmark and what does it tell us about patients. Again, just at the meeting we saw probably controversy that what do we take away from looking at a patient's reduction in BCR-ABL levels at 3 months and 6 months, combining them? Do we look at a black and white landmark of 10% on an international scale, starting generally at 100% on average? That's probably being too general. And there were presentations looking at even an earlier assessment, 1 month, and looking at the speed with which the BCR-ABL level declines over that month.
So not necessarily just an absolute level, but the rapidity of the drop.
Absolutely, which is really probably where we want to be, which is looking at it on a patient-specific level. But we need to validate those data further. We've seen a lot of large studies showing black and white questions about 10% transcript levels, but I think ultimately we're going to want to look at that as a guide and then look at a patient's individual trajectory to make sure we're not either being too critical or too lenient based on their response. So that was the take-home message.
So the jury's still out a little bit on that as to know exactly what is the best metric. But in general, the current recommended guidelines are not being adhered to perhaps as well as they should be. And for now, we should really focus on that.
I think it's safe to say that people should pay attention to early molecular monitoring because especially if they're, for example, using imatinib. I think we're still at a point in the U.S. where we use imatinib, nilotinib, and dasatinib pretty much in equal portions. We haven't seen a paradigm shift that's in entirety with regards to using second generation.
It's pretty well a three-way split, is it, between those 3 drugs?
If not that close. So optimizing response, and that's what comes out of the early molecular monitoring. So that's where you put it all together is, look at the guidelines and adhere to them if you should and you can. Understand there's a little controversy on what might be the absolute best test, and probably individualize it for each patient and not be too critical.
Okay, great. Well, let's move from the upfront setting now into the relapse setting. We know that, unfortunately, despite these great deep molecular responses, we still haven't really cured the disease per se. Most patients will end up responding. Anything from the relapse setting that has been particular? I understood that there was some work looking at those patients initially treated with imatinib and then into dasatinib, trying to optimize the right dose. And talk to us a little bit about that.
Now this data has been running for a long time, so we had a very late follow-up from, as you mentioned, the study looking at patients post-imatinib who received dasatinib.
Okay.
And as we looked at with the frontline study, we want to have similar questions. What do we see with regards to some of the expected toxicities? But importantly, can a patient do well over the long term, with a salvage therapy like that? And indeed, there was a nice tail on the curve, if you will. The patients could respond long term to dasatinib, even some patients who didn't have ideal response. And indeed,
ideal response previously from imatinib the first time, or just initially with dasatinib, and it just took longer for them to respond.
Exactly. That they may not have had the ultimate deep molecular remission, but they can still do well, if you look at the progression and survival.
Okay.
So, and of course, looking at toxicity, looking at pleural effusions and other things specific to dasatinib, I think we didn't have any big signals with regards to new concerns in a population we're following over a longer period of time. And again, those patients have been followed for a longer period of time. Probably a little bit more attention was focused on the newer kinase inhibitors used as an alternative for patients with probably multiple drug failure or highly resistant mutations.
So that's reassuring then about what people can, that we can have that good an outcome in patients who have had long-term dasatinib.
Mm-hmm.
Well, let's talk a little bit now about ponatinib. That's been
Yes.
kind of a hot topic, and we know there were some challenges there where the drug was held for a period of time, the concerns about toxicity. Why don't you first tell us about that? What exactly happened with ponatinib for those who may not be familiar?
So the phase 1 trial was mature and had been a classic 3x3 phase 1 trial. Came up with an MTD. We had a large phase 2 trial called the PACE trial. So things went along nicely. The drug was approved, and about a year after, there was more information about toxicity that was emerging. We were starting to see over time patients were having vascular occlusive events. And of course, there's the devil's in the details with regards to how you quantify that and how do you attribute them to drug, and that's a challenge. So I think being conservative, we had a hold on prescribing authorization for 3 months while the FDA looked at the data. The European Medical Authority looked at it as well, and we had some label changes. I think we understand that drug's very effective and very useful, and there's definitely an unmet need for it. But on the other hand, it's a new world. We have targeted therapy where looking at MTDs and looking at some of the early safety signals might not be as helpful as what we learn over longer periods of time. So I think that's a lesson learned.
So the indication didn't change, it was more of the product labeling around certain risks?
So the label did change in the US slightly in that it was now registered for patients who have a specific mutation, the T315I, but importantly a broad and really left up to the clinician statement for patients in whom no other TKI is indicated. So that could mean patients in whom there'd be lesser odds of response based on available data, concerns about intolerance or previous exposure and intolerance to other TKIs. So it's still a fairly broad indication, but a little bit more conservative.
Yeah, so it sounds like there's still, I don't want to say open season, but there's still quite a bit of flexibility and give as to the selection of these 3 agents.
I think people often they probably would like a little bit more granularity. Can I use it as a second line or a third line or after certain drugs? And the European medical authorities have a little bit more direct information label, but actually it's a little bit more liberal. So I think the most important thing is to understand the latest information about toxicity and actually to stay tuned, because a lot of work's being done right now in trying to sort out what is the mechanism of action, how can we manage it.
Is the incidence high enough that these patients are being thromboprophylaxed, or is it more an ad hoc basis looking at other risk factors and intervening with prophylaxis when needed?
I think it's a little bit controversial because we don't know what the benefit versus the risk might be, particularly with the hematologic malignancy patient and antiplatelet agents, and drug interactions with lipid-lowering agents, other things. I think pragmatic advice would be to take a patient who has CML or Ph-positive leukemia who might need a drug like this, and it might not be specific to ponatinib, and make sure their cardiovascular risk is assessed and do what's needed almost irrespective of their CML, and then move forward with the TKI. We may see in trials subgroup analysis of patients that might receive something specific for this risk, and then we'll understand a little bit more about it, so that data is forthcoming.
Okay, but at present we're not sort of prophylaxing.
I think that might be overarching to make broad recommendations about aspirin or lipid-lowering agents.
So in summary then, for the ponatinib, obviously it was held for a period of time because of this risk of vaso-occlusive events, which now we seem to be able to characterize a little bit better. We can use the agent, but it just has to be considered in the light of every individual patient.
Exactly.
Okay.
And
Great.
With some of the nice data that we saw at this meeting regarding ponatinib, though, was looking at long-term follow-up of the phase 1 trial, and long-term follow-up particularly of the patients with a T315I mutation. And I think the messages were that patients with the T315I, not specifically because of that mutation, probably because of their characteristics being a bit younger and having more intensive therapy, they actually do very well, chronic and accelerated phase.
Great.
And the safety profile is what it is, but balancing that risk-benefit ratio is favorable for those patients. And then when we look at long-term follow-up from phase 1, the trial, as you might expect, would have patients treated at lower doses. So if you look at patients who had less than 30 milligrams through their course of treatment from start to now, they actually do quite well. And that's the next step with ponatinib, is to probably ask the question about using lower doses at the start and reducing the dose as a strategy, almost like an induction and maintenance approach, which hasn't been done in CML.
Now, did those long-term follow-up patients with the lower doses have less toxicity?
When we looked at patients who were dose reduced, we see that there is a decline in adverse event rate. I don't know if we can say that the adverse event rate was necessarily lower in the patients who hadn't had the highest doses. That analysis, I'm not sure if we have the data, but what we can say is that the response was equal to the cohort of people exposed to higher doses.
Okay. So it's pretty clear that ponatinib is still going to be a part of what we do in relapse therapy, and that's great. Well, before we close off, let's look to the future. People always want to know a little bit what's coming down the line with all the IBs that you have now. Imatinib, nilotinib, dasatinib, ponatinib. What's the newest IB? What's coming that may perhaps even further benefit patients with CML?
Well, it doesn't have a name yet.
Okay,
with ending
so
in
there's
IB.
no IB yet. Okay,
No IB
good.
yet. There was a report at the meeting about a drug called ABL001, which is a novel kinase inhibitor. I think it's a very good lead compound. What we know now is preclinical data, and that's what was presented.
Okay.
It is in clinical trials, and which is exciting, and I think that we'll have preliminary data from that soon. But what we saw was the concept, and it blocks the ABL kinase, which is a driver of CML, not by blocking where the current 5 drugs are working, but at a different location, a different moiety, different kind of way to turn the kinase off, or actually keep the kinase in a configuration that would favor an anti-leukemic effect. So preclinical data was presented from the manufacturer in a very nice presentation that showed in animal models the kinase inhibitor ABL001 works by inhibiting this other site. Resistance can develop at that site, as one might be worried about, and we know resistance occurs when we use other available kinase inhibitors like nilotinib, for example, but the drugs are complementary. One will overcome the mutations of the other, and we saw very nice data that the combination might be really the way to go, because they may cancel each other out, and we may have a dual-pronged approach, which we haven't seen in CML, using multiple kinase inhibitors that could be quite successful.
Wow, so you're kind of trying to close the doors in the house, and one can shut the front door, one can shut the back door, and if there's resistance to it, then the other one can close the other door.
I like that analogy. Wow. I might have to borrow that.
Yeah. That's no copyright on that. So this, again, might herald a change in concept of potentially combining these two agents together.
Yeah, I agreed. I think we borrow a lot in hematology sometimes from infectious disease, and I think a good analogy might be how we've made great advances in HIV medicine by understanding
combinations.
Exactly, multiple mechanisms of action or multiple sites on the offending agent, and you can make a more lasting and more definitive impact.
So ABL001, something
Look for that.
To be watched for. Maybe one last question about it before we close, Michael. Any unusual toxicity with this agent?
We don't have.
I know it's early, right?
Yeah.
And this was all preclinical?
All preclinical.
Okay, so it's too early to tell.
I don't know if we have that yet, but I'm encouraged.
Okay, excellent.
Yeah.
Well, thank you. It's been a delight to have you here, and been able to teach a simple myeloma doctor a lot about CML, and I appreciate it.
Well, my pleasure.
It's great to have you here, and thank you very much for joining us again in our series, in the Best of Day series here for IMEDX at our annual hematology meeting. We've learned a lot today. We've learned a lot this week about various new compounds, various approaches to therapy, great advances in the field, and we trust it's going to be helpful to you in your practice. Again, thank you for joining us, and we look forward to having you at future events.